My name is Giacomo Bellani. I come from Monza, Italy. We are an ECMO center for, I would say, the northern part of Italy. We have been doing ECMO also, I would say, in the dark ages, let's say before H1N1. My boss, Antonio Pesenti, I would say he's been one of the leaders in the pioneers in the field of ECMO, so we kept running ECMOs. I've been familiar with these techniques since I was a kid, a student, and now of course we run maybe around 30 ECMO runs a year, depending a little bit on the flu season and outbreaks. Today my talk is not about ECMO. It's about what we should do before ECMO, and I guess I was given this talk because sometimes I tend to have a little bit of a skeptical view around the ECMO-ish thing. So I want to ask you, how many of you have seen the cult movie Karate Kid? Okay, so I don't feel that old. So at some point they asked the question, why do you learn karate? And the answer is, so I don't have to fight. Okay? And so we learn about ECMO because we want to make sure we do not get to the point where we have to do ECMO. We have to make sure we do everything before to avoid getting to the point we have to set up ECMO. And sometimes this is unfortunately not the case, as I will show you. So what are the very basic principles of ARDS treatment for as much as it can be told in half an hour? Sorry, I should have started with my conflicts of interest. I was supposed to give a case-based presentation. So this is my case, 23-year-old female, no past medical history, healthy. She was admitted in the emergency department with an headache, a fever. Hemodynamics were okay, I would say. Very high level of procalcitonin, a negative CT scan, but spinal puncture positive for pneumococcal meningitis, and so she started the antibiotic and she was admitted to the infectious disease ward, to the floor. However, after 6 hours, she is still awake, reactive. She starts to complain dyspnea, and under, let's say, 10 liters of oxygen, her saturation is 93%. So the colleagues, sorry, this should have shown up before. The colleagues asked for a chest X-ray, and this is the result, which is, as you see, a chest X-ray which is compatible, I would say, with the ARDS. We have bilateral infiltrates which cannot be explained by fluid overload only or by pleural effusion and so forth. So to make a long story short, she's admitted to ICU. Her hemodynamics is still stable, I would say, and she's well awake and conscious. The headache is now getting better, and she's on antibiotics, as I said. The doctor in the ICU starts some non-invasive ventilation because of the chest X-ray and the complaint of the dyspnea, with a PEEP of 8 centimeters of water, 8 centimeters of water pressure support, and this is the ABG we got after 30 minutes. I brought you the values in millimeters of mercury and kilopascal. So FiO2 is 40%, PaO2 is 105, PaCO2 is 40. Would you go on with NIV? Who would go on with NIV? Who would intubate the lady? Who would go home and ask the colleague, see you tomorrow? Personally, I think I would go on with NIV. The oxygenation is not bad. This looks like a moderate ARDS, I would say. This PF should be around 200 and, no, it's mild, it's 200 and, it's above 200 anyway. And the PaCO2 is now fine, is 40. After 6 hours, this is the blood gas that we get. The colleague tells us, well, yeah, I had to crank up a little bit the FiO2, it's 0.6, but the oxygenation is still fine, and she's doing well. what would you do? Are you concerned? Is there anything that bothers you in this blood gas analysis? CO2, okay? Now, we are very well concerned when PCO2 is 60. If I told you PCO2 is 60 and pH is 7.3, 7.29, you would have said, okay, we need to intubate the lady. However, a low PCO2 is also a concern. Because what is the reason that PCO2 is low? Because minute ventilation is very high, okay? And if I was to go to the desert island and I had to bring with me just one result from the lung safe study, I would bring this one with me. This is the PCO2 over the different severity degrees of ARDS, mild, moderate, and severe. And this is invasive ventilation, and this is non-invasive ventilation. Wait to take the picture because then it gets better. Okay? And so if you look at PCO2, it increases from mild to moderate to severe. Well, it ain't rocket science. You did the lung safe to prove this, because these patients are less ventilated, they have more dead space, blah, blah, blah. But look at the non-invasive ventilation. PCO2 goes down. The more severe is the patient, the sicker is the patient, the hardest she, in this case, is trying to breathe, because she feels like she is dying and she wants to breathe. And she doesn't care about ventilator-induced lung injury. She hasn't read the book on ventilator-induced lung injury. She didn't go to conference. She just wants to survive. And she's breathing as hard as she can to keep her lungs open. Can this be injurious for the lungs? It might be the case because, as we have shown again with the lung safe, if we look at the population of patients with the PF ratio, with the PF ratio above 150, there is no difference in mortality between invasively and non-invasively treated patients. But there's definitely a signal which for harm of the patients for the patients treated with non-invasive ventilation when the PF ratio is below 150. So I'm not saying we cannot use NIV in these patients. I'm just saying we should be very, very, very cautious, because the patient could be injuring the lungs, her or his lungs, without us recognizing it. And it was interesting to notice in this paper by Guillaume Carteau that one of the predictors for NIV failure, besides the usual known, PF ratio, SAPS, blah, of course, it is the minute ventilation during NIV. Sorry, the mean tidal volume during NIV. The higher the tidal volume, the greatest the chances for the patient to fail. So we decide we don't want to go on with NIV for this girl, for this young lady. So we go for invasive ventilation, and we intubate the patient, deeply sedate her, give volume control ventilation. Of course, with sedation, there's always some hemodynamic instability, and there's sepsis, so her fluid balance is already positive by almost 2.5 liters. And this is the mechanical ventilation parameters that we set. Tidal volume is 400 ml, respiratory rate 24, PEEP 5, plateau pressure 23. And this is the ABG. 7.38, PCO2 53, PaO2 99 on pure oxygen. Are we happy with that? Oh, hey, who's happy with that? Who's not happy with that? What is the number that bothers you the most? Oxygenation. Anybody else? What's that? The tidal volume, we don't know the height. You're like, this is a mechanical ventilation guy, must have to do with mechanical ventilation. Well, in this specific patient, the numbers that bothers me the most is this one. If this patient had any other diagnosis, I would be extremely happy to see 53 PCO2, 7.38. But remember, she had pneumococcal meningitis, okay? So we need to make sure that we save her brain first. So this is the only situation, almost the only situation except I would say an acute cor pulmonare where we should target a normal PCO2 rather than a normal pH, okay? If this girl had pneumonia, septic shock from whatever else, H1N1, name it, I'm totally happy with this ABG. If I suspect that there is a problem in the brain, then I'm not happy with this ABG any longer. So in this particular case, the first number I would change is respiratory rate, make it 30, and PCO2 is now normal, pH 7.44. I'm, let's say, fixed the brain, and now I can start thinking about the lungs, okay? So what is the number that bothers us now? Driving pressure and oxygenation. The PF ratio is now very low, is actually a little bit higher, but we are on the edge between moderate and severe ARDS. And we have a minute ventilation of 12 liters per minute. This is the other side of the coin. It is the reason why oftentimes we need ECMO, not just to rescue hypoxemia, but also to protect the lungs. Because that space is the other side of shunt. If there is shunt, there is dead space, and vice versa. Okay, this is a lesson that Antonio Pesenti always taught us during rounds. And if you're a resident and you have to present your ECMO case in front of Antonio Pesenti, I'm telling you, you'd better know what you're talking about. Anyway, minute ventilation is very high. And so this patient, even though we could perhaps be on the, still in a, I would say, decent range of oxygenation, will likely have her patients injured by the burden of ventilation. And as it was said, also driving pressure is very high. We have a driving pressure of 23 minus 5 centimeters of water, which makes, if I was not too drunk when I made this slide, 18. For 100 ml divided 18 is 22 ml per kilo. This compliance is very low. I didn't tell you anything about the size of this lady, but let's say she's a normal height, as we will see. This compliance is very low. So this means that her lung is very small, okay? Baby lung concept. So what is the first, let's say, the basic of ARDS treatment, okay? It's like climbing a stair, okay? So think of your patient as she's moving downwards in a more severe situation, from mild, and we started with NIV, to moderate, and to severe. So it doesn't matter which patient we are dealing with, we should go for a low tidal volume ventilation. What is low tidal volume? I'm Italian, I'm quite lazy, so I like easy formulas. There is a formula long like this to calculate predicted body weight, but as I said, I like this one better. For men is height minus 100, for women is height minus 110. This is the ideal or predicted body weight. So let's say our lady is rather tall, 175 centimeters, 65 kilograms is her ideal or predicted body weight. Target tidal volume should be 390. We are at 400, I would say. Okay, we can live with that. Would you agree? So what else can we do at this stage to improve the situation? We move on the stair that these experts put down for us. So I think that there's little doubt, well, I'll go back to this. The experts recommend that the more severe is the patient, the higher should be the PEEP. Now, why did they say this? Because there is a growing body of evidence in the literature that patients with a moderate or severe ARDS, now this is the red marks are according to the Berlin definition, patients with a moderate to severe ARDS would benefit from a higher PEEP, would have a benefit in mortality. Now the hazard ratio is 0.85, so it's overall a 15% reduction risk in mortality. Whereas there is a strong signal which indicates that patients with a milder ARDS would benefit for a lower PEEP. Now, what is higher PEEP or lower PEEP? In this experiment, in this study that is a meta-analysis of several randomized controlled studies, higher PEEP was around 15.3 centimeters of water and lower PEEP was 9. What does it mean? That we should use 15 centimeters of water in all patients with ARDS, with moderate and severe ARDS? No, I think the idea is exactly this one, higher and lower. So, in other words, also in this, I suggest you to read this paper because it's very nice. In this review on the JAMA, Fan and Brody and Zlatsky suggested to consider higher PEEP in moderate and severe ARDS. So higher, what does it mean? Higher than what? Higher than 5, higher than 10, higher than... Higher means, in my mind, that we should aim for a PEEP increase. We should test an increase in PEEP the more severe the patient is. We should allow the lungs that can be reopened to be reopened and to be kept stable by a higher PEEP. How would I do this? Would I aim for a higher PEEP? Well, this is just I'll skip this for the sake of time. How would I aim for a higher PEEP? We are very much interested in the respiratory mechanics of the lung. We used to call it a higher compliance. Now we prefer to call it a lower driving pressure, but if you use the same tidal volume and you change PEEP, it's exactly the same, a higher compliance or a lower driving pressure. So we know that if we are able to increase the PEEP and we observe a decrease in driving pressure, this will be associated to a lower mortality. So now our girl is in this column here. She has a, I would say, safe driving pressure, safe plateau pressure, but she has a very high driving pressure and a very low PEEP. Can we do something for this? Perhaps we might. Wow, I put too many slides. What we do is try to guide our PEEP setting according to driving pressure or compliance. So this is just an example. We start from 0 to make the calculation simple. We increase the PEEP from 0 to 8, and we see that plateau pressure increases only by 6 centimeters of water. So driving pressure goes down. We are going towards a better compliance, likely meaning recruitment. And the more we increase PEEP, 12 centimeters of water PEEP, the lower becomes the driving pressure. You see now we increased PEEP by 4 centimeters of water and plateau pressure increases only by 2 centimeters of water. This is a very, very encouraging finding, not scientific finding, a very encouraging symptom that the increase in PEEP is promoting recruitment of the lung, or at least is avoiding collapse. And then we like this trick, so we try to keep going with PEEP. This is the same condition as the last slide, but at some point we increase PEEP by 2 centimeters of water and plateau pressure increases by 4. What does it mean? It means that we are hitting our head on the roof. It means that we reach that point at which the lung is overdistended. And so we can go back to the previous level of PEEP, or we can decide to decrease tidal volume to keep the driving pressure within a safe range, and we avoid overdistension. This is PEEP setting guided by respiratory mechanics. Of course, there is not just respiratory mechanics. We can build a PV loop, but I don't have time to go into this. There is not just respiratory mechanics. We got very much interested into electrical impedance tomography. And as you see here, you can use a recruitment maneuver, for example, not just to obtain an improvement in oxygenation, not so much as a therapeutic tool, but as a diagnostic tool. Here, we have our end expiratory lung volume. We give a recruitment maneuver without changing PEEP, and we see that, yes, there is recruitment, but the PEEP is not high enough to keep the lung open. And you see, we lose all that we gain. And we give another recruitment maneuver. We increase PEEP only by 2 centimeters of water. It's not like those animal studies, you go from a PEEP of 2 to a PEEP of 18, okay? It's just 2 centimeters of water, but look at the difference. We now obtain a stable end expiratory lung volume. So we have done our tricks, and now we have a PEEP of 12 centimeters of water. Our plateau pressure is 24. And I would say we are much happy, more happy from a mechanical standpoint now. Would you agree? Would you agree or not? No? I would say we are in a better condition because now plateau pressure is slightly higher, but the driving pressure is much lower and compliance is higher, sorry. However, we have to take into account also oxygenation. An oxygenation decrease after a PEEP increase is not a good sign. It means that we might have an hemodynamic problem. It means that we might be over-distending the lung. But in any case, a loss of a decrease of PF ratio, a loss in oxygenation after a PEEP increase is associated with an increased risk of death. So I would say, on one hand, we are happy. On the other hand, we should be quite concerned. So what to do in this case? I don't have an answer, honestly. But, you know, it's always easy to come here and do a case where everything is straightforward. We increase PEEP, the patient wakes up and everything is fine. I mean, it's life, you know. Sometimes mechanics go in a direction and oxygenation goes in another direction. So what else do we have on the stair here from our experts? We have prone position. Prone position has been shown by several studies to improve oxygenation and to protect the lungs. I don't have time to go into all the details from the, let's say, classical physiology studies, but as you are aware of, as opposed to, for example, FiO2 or nitric oxide, prone position does not just improve oxygenation, it does protect the lung. It reduces overdistension and promotes recruitment. And this study, after several, I wouldn't say negative, but let's say neutral studies, was able to, in this study led by Claude Guérin, the investigators were able to show a clear signal in favor of the prone position versus the standard treatment in the supine position for patients with a PF ratio below 150. And the reason I think this study was finally successful was that it was very wisely designed. It was built on all the evidence that they had gathered from, as I say, the physiological study and the previous outcome studies. So they focused on the most severe subset of patients. The pronation was applied very early in the course of the disease, and there were very long pronation sessions, say maybe 16 hours a day. And if a patient worsened the oxygenation after 2 sessions of pronation, the maneuver was discontinued. Sorry. So, if we look at who are those patients that are more likely to benefit from prone position, these are those patients in whom protective lung ventilation was used. It is useless to use prone position if we do not use lung protective ventilation. These are the patients in whom prone position was applied for a longer period, up to 16 hours per day, and definitely there is no benefit for patients with mild ARDS, some benefit for patients with a moderate ARDS, and definitely an advantage for patients with a severe ARDS. And some authors, as Guerin did, use the cutoff, which cuts the moderate ARDS in half of 150 millimeters of mercury. Unfortunately, again, we know that from lung safe, prone position is not very used. It's been used in our cohort only in 13% of the patient, and Claude Guerin did an observational study, and prone position was used there. I guess it was maybe 20% of the severe ARDS. And you might be thinking, well, you know, LungSafe had so many hospitals, also regional, smaller hospitals. This is an ECMO masterclass. We all do prone position. How many of you would do prone position before ECMO? How many of you would do ECMO without prone position? Well, Brian Kavanagh analyzed some published papers. These are published papers, okay? He didn't go and look and spy in ICUs. He just looked at published papers. And these 17 published papers that gather 672 patients, papers on ECMO, done in ECMO center by well-qualified investigators. In these papers, prone position was used before ECMO only in 31% of the patients. And still, 69 received ECMO before prone position. I think that still, of course, despite, and I guess you will be discussing the Eolia trial quite a lot, I'm very much convinced that despite this a little bit skeptical view I've given you, there is definitely a place for ECMO for the more severe ARDS patients. But I think we have to remember that ECMO is on top of this stair, is not here at the bottom. So going to my conclusion, I think the ABC is that we should give patients an NIV trial. We might, if we want, if we are confident with that. There's nothing wrong in giving the patient an IV trial, but we have to be extremely cautious when the PF is below 150 millimeters of mercury. Little discussion on tidal volume. I think we should aim for a higher PEEP in patients with a moderate to severe ARDS. I think we have to look at the response in terms of driving pressure, compliance, and oxygenation. We can consider recruitment maneuver, as I was showing you, also as a diagnostic tool. And I think that I'm positive that ECMO saved many, many lives. And we are here, and you are here because you want to learn more about ECMO, which is totally fine. But I think this is a statement that we should keep in our mind. No patient should receive ECMO before receiving prone position, unless, of course, there is a clear contraindication to prone position, and this goes without saying. Having said that, I thank you very much for your attention.
Okay. Thank you very much, Giacomo, for your interesting talk. Any questions from the audience?
I scared them.
No? So I have one. So as you said, the PEEP titration is a very important issue. In terms of tools to guide us in the PEEP titration, except arterial blood gases, of course, do you suggest anything particular? Or maybe?
Well,
have any experience?
honestly, it's a little bit, I was a bit fast, but it's very much what I've shown you. So blood gas, of course, is one aspect, respiratory mechanics, and we use quite a lot nowadays EIT. Some colleagues are more familiar with ultrasound, and they do it. Personally, I am not a super user of ultrasound for the lungs, but I think it's fine. In a more obese patient, I shall say, we use esophageal balloon, but honestly, this is something which comes later on. So if a patient is maybe already on ECMO and we are going very high with PEEP and we are not very confident, then we swallow an esophageal balloon. But that's not our, I shall say, routine approach. I just would like to say, to stress what you said, the fact that we have to monitor something when we increase PEEP. So like increasing PEEP, decreasing tidal volume, increasing respiratory rate, decreasing FiO2, and looking at the ABG 2 hours later, it's not a very reasonable approach. And I know it looks quite obvious to say this, but it is still sometimes what happens. So I think we should have clearly in mind what we want to monitor, do a PEEP adjustment, and reassess.
Okay, lovely. Thank you.
Thank you.
Thanks.
Yes, please, from the audience.
What about using high-flow nasal cannula instead of NIV in this patient?
Yeah, I mean, it's an option. I think it's a great question. It's an option. This could add the fringe benefit of somehow enhancing the CO2 removal, so maybe decreasing the minute ventilation, and so this could maybe also be a little bit protective for the lungs. I think for high-flow nasal cannula, it's more or less the same as for NIV. We are paying a price. We are using less pressures, less PEEP, I would say, than for invasive ventilation. We are using higher FiO2, and we are allowing the patient to be free and to breathe. So again, we have to closely monitor what's going on. But it's a totally doable option. It's a totally doable option. The fact that, I'm just stressing the point that the fact that there is no positive pressure, it's not necessarily less injurious for the lungs. That's why I'm trying to say.
And would you switch from high nasal cannula to NIV, or if the patient is not...
And normally what we do, our first line intervention for, let's say, a mild ERDS, like a girl like this, would be to go for helmet CPAP. This would be our choice. We are very much users of helmet CPAP, and normally we go with that. So because what we want to do is lung recruitment, positive pressure. This girl was not exhausted. She was not a COPD patient, not able to eliminate CO2. So if there is a fail to this first line intervention, we would go maybe for intubation. But I think it's also possible to go from high flow to NIV. I think there's we need more data to know whether this is doable, or if a failure from a high flow should immediately prompt intubation.
Okay. Thanks so much, Giacomo, for your great talk.
Maybe there is
Other
no
questions?
Okay.
Yes.
No, please. Yeah.
Giacomo, thank you very much for that brilliant talk. But I just would like to ask you to comment on the situation for PEEP titration. Do you really go on a zero PEEP level?
No, yeah, sorry. No.
Please say this.
Yeah, no, sorry. Thank you very much. No, we do not do that. I mean, normally we start... this is for just, like to make the numbers easy to understand, but we do never set, thank you for asking this, it's very important, and maybe I will have to change this slide. We never go to a PEEP of 0, we never start from a PEEP of 0. We normally start from the PEEP level that we have immediately after intubation. So in this case, it was 5, and we would go up from there, or from 10, and we would go up from there. So the idea is that the more the patient is hypoxic, the higher you want to go with PEEP. So we do not really start from a PEEP of 0 just for the sake of knowing that the lung is recruited and the patient will immediately become super hypoxic. Thank you for asking this.
Thanks again. Really quick and short question, please, because
It will be a short answer.
I'm asking about the regarding prone positioning. If I start prone position and the patient is improving, so I can do it for how long? For how many days?
Well, what has been done in this study, we keep going until, let's say, the PF ratio is above 150, something like that. For how many days we have patients who received a cycle of prone positioning for 7 days, for example. But clearly, if the patient after day 1, 2, 3 is not responding to prone position, that is the moment you want to think about ECMO, because delaying ECMO, as for sure you will hear, is something that will highly harm the patient. So if after, let's say, 2 days of prone position, the patient is still severely hypoxemic, then perhaps it's a good time to go to ECMO.
Great, thanks.